It's now time for the live Q&A. We turn you over to our moderator, Dr. Eugene Lee Barinaga, for our live Q&A.
So thank you, Dr. Robles and Dr. Calderon, for the wonderful lectures. Personally, I learned a lot, and recently our family had an experience regarding yun nga, the brain death determination and making decisions in the ICU. So we have many questions from the audience, and some are similar. So kinulit na lang namin. So let's start with questions for Dr. Calderon. So question number 1. Dr. Calderon, what can you advise nurses who are often asked by patients and family about their opinions on ethical decisions? Besides talking to the attending doctor, how should you think nurses react ethically to the patient and family?
I really wanted to answer that question live because I know that I'm not sure how many, but our audience also include nurses, no? Thank you very much for that question. I think it's time for nurses to be involved in the conversation. If we really want this to be a healthcare team, and if we really call ourselves members of the team, then nurses should have their voice in that conversation. After all, correct me if I'm wrong or if you dissent to my opinion, I think it's the nurses who are by the bedside who really know the patient and the clinical course very well. So in terms of the care, the emotions, and the relationship with the patient and the family at times, no? So I think nurses should be given a voice. But then, given our culture, I know it's not the doctor as the captain of the ship, and everybody else is just it's just auxiliary. I think it's time to have an interprofessional dialogue on this. I don't know who should be the promoter, but I suggest it should be the PMA and the Philippine Nurses Association talking together. So we have to break the barrier of doctor nurses. And
yes.
Involve them in the conversation.
Yes, I agree. Lalo na this pandemic has taught us that in dealing with diseases, not only with the pandemic, it should not be a doctor-centric approach. No, we see during this pandemic, everyone's role, especially the nurses, the medtech, the radtech, respiratory specialists, everyone is really given the time to shine. So I agree with Dr. Calderon, nurses and other paramedical staff should have a say and should be actively involved.
Yes, sir. And if I can add to that, no, at St. Luke's Medical Center, when we conduct our bioethics committee family meetings, we invite the nurses, no, to be involved in the conversation because they can provide facts, they can provide more. In fact, sometimes they provide more relevant facts, no. So, and their opinions also matter. So I hope this can be a good example, no, set out for all of us present here. Thank you.
Another question for Dr. Calderon. If a patient has a known record, then you said the AMD should be the one to make his or her own decision towards the patient. Can that AMD be sued later on if ever the family or relative of that patient is identified or they come out? Can the AMD be sued for his decision?
When I talked about the unbefriended patient, some of my colleagues here around me asked me, ano ba yung unbefriended patient? So I just gave a classic representative example. Sabi ko, paano kung taong grasa? No, so I think that's one classic, stereotype example, but it speaks for itself. No, wala siyang kamag-anak, walang magko-consent sa kanya, and the patient is unconscious. Now the patient comes to you, is brought to you, and then you provide treatment. then later ayaw pala nila ng treatment, ayaw pala nila ng resuscitation, will you be sued? Yes, they can sue you. But will the doctor win? Most likely. I'm not a lawyer. I can't speak for the judge, but there are legal precedents to this in the Philippines and also internationally. Kasi our basic rule is, or the mantra is, if you are going to commit an error on the side of life or commit it on the side of safety. So if you save the patient, ayaw pala niyang ma-save, then problema na niya yun. In other words, legally speaking. So safe po tayo if we're going to save patients, even if we will provide saving, we will institute life-saving procedures to our patients. And that also happens even if patients are suicidal, for example. So sabi nila, Doc, bakit mo pa ako niresuscitate?
Yun yung tatanong ko dapat.
Oo, ayoko na nga. No? So, didemanda ko yung doctor ko. Well, then again, I think the court is likely to side on the doctor who was on the beneficent side. So,
yeah, actually, yun yung tatanong ko, isisingit ko dapat. It happened fairly recently in our government institution, no? Suicidal attempt and nabuhay, dinala. Tapos, alam mo yun, yung hindi naman sa inhumane na yung mga residents namin, pero parang, ba't pa tayo magiging aggressive? Gusto nga mamatay ng tao. So, yun yung question na yan, lumalabas. For Dr. Robles, there's a question here. Is coma and being brain dead similar or different? And can coma be one of the cause of being brain dead?
Okay. I'd like to say hi to Dr. Calderon first. Thank you, Dr. Barinaga, for that question. If you noticed, one of my slides actually talked about the prerequisite being a comatose patient. So hindi lahat ng comatose na pasyente ay brain dead. But every brain dead patient is comatose. So there are a lot of causes of coma. Kung ako ay hypoxic dahil ako ay nag-COVID, I can be in a comatose state. There are progressions or there are grades of coma. So pwedeng obtunded ka lang, pwede ka na GCS 3 to 4. You will still be called a comatose patient because you still are not aware of your environment or you're not interacting with your environment. So there are really a lot of nuances to the definition. Masyadong maraming terms ang neurologist for the different states of coma, but it's a gradient, it's a scale. So you have the ones that are gising na gising, and then you have the ones that are comatose. And there's a lot in the spectrum. Now, if your patient is anywhere in the spectrum but a coma, imposibleng brain dead sila. So if you already have a patient that is definitely comatose, unresponsive, GCS 3, walang interaction with the environment, stimulate light, nagre-react. Kung nagre-react ang pupils niya, when you actually do your evaluation of the neurological exam, this patient is not brain dead kasi you have pupillary light reflexes. Remember, yung requirement natin would be no brainstem reflexes, and that includes no pupil responses, no corneal reflexes, no cough reflex, no gag reflex, none of the other reflexes that are possibly present. Maybe spinal reflexes lang, but anywhere up, dapat wala. So that's how you can differentiate. Now, the second part of your question was whether they can progress from being a comatose patient to being brain dead. Tama ba?
And can coma be the cause of being brain dead daw? Yung
It's not actually the cause. It's one of the prerequisites. Other injuries will be the cause of the coma, thereby allowing you to assess this patient for brain death. So if head trauma is the cause of my coma, and then persistently comatose yung patient with no neurological reflexes, then I may assess for brain death. If, for example, severe prolonged cardiac arrest ang cause ng coma, because nag-hypoxia, nag-hypotension, nagkaroon ka ng pamamaga ng utak because of the prolonged 30-45 minute CP resuscitation, then that will be the cause of your coma. and that may cause the brain death. So coma is just a part of your brain death. But coma is not automatic brain death, brain dead ka na. I hope that spells out the difference between the two. So it's probably easier to remember, hindi lahat ng comatose ay brain dead, pero dapat comatose ka para ma-assess ka for brain death.
Having brain death. Yes.